So do it right, because again it's technique dependent. So Oxford has evolved from understanding of wear. What is wear? And that design is designed as a design against wear to start with, to reproduce the function of meniscus. Then understanding the knee wear and the word anteromedial osteoarthritis have come into the picture. There is a wonderful paper in 1991, nothing new, 91, AMOA as an entity in the knee. Then there is a beginning of second phase 2. Clear Oxford criteria came accurately based on pathoanatomy. The most important thing is microplasty instrumentation system since 2011, which is more reproducible, consistent and easy way to achieve consistent results in your patients. So sagittal plane is a default plane mentioned in the system. You don't have to worry about sagittal plane things like in total knees. It will be taken care by the system. And coronal plane is your plane. You decide as a surgeon and you have a chance to play with. So there are three things: the femoral drill holes, tibial vertical cut and meniscectomy. That's it. No other steps you have a control. This is all done by the instrumentation system. That's the beauty of this surgical technique. Still, the commonest concern, very common, these are our own case of tibial condyle fracture, bearing dislocation can happen, and overcorrection due to over-release on the medial side with progression of disease. These are the commonest concern if you do not pay attention. So the things you should understand is one beautiful statement by Professor John Goodfellow that Oxford is an intellectually exciting but technically demanding procedure. So this is your right patient selection criteria. You must be intellectually ignited to find whether it is AMOA or not, and then there is a learning curve. Of course, you have to learn the right technique. So right patient, right position, right execution and right function. So compromise X-ray means confusion, MRI, arthroscopy, we have all, an on-table decision is not a right thing. I personally feel once in a while is fine. You should not tell your patient all the time that I will take a call in your knee in every single time that you may need TKR. You may need once in a while, it's okay. Like every single time, I think it is your lack of confidence and it is impossible to have a backup all the time. And when you are doing Oxford, it is very difficult to convert it onto a TKR position to do total knees. So all small, the sizing is very, I think we will skip this, we'll discuss when we do this. But these are the commonest algorithm. The female patient less means average height more than 5 feet, you have small femur. And there is A or B, most commonly utilized, sizing of a tibia. And male patient is medium. The easiest way to remember is boys are blue and girls are pink. So these are color code. You can easily remember in your 95% of Oxfords. These are the sizes that you can select very easily. So let us go with the steps. These are the trays. This can be provided, and you can, life begins with the color code. So all male patients usually you have a blue tray, and all female you have a red tray. Very rarely you need other trays on table. Hanging leg really makes sense to do the uni in a gap balancing technique. It's not a measured resection, pure measured resection technique. And in TKR, it's a 0 degree is your extension gap, 90 degrees your flexion gap. In Oxford, it is 20 degree flexion is your extension gap, plus 90 degrees or 110, which is your natural hanging leg position where you measure your flexion gap. So bilateral, you need a split table and not start with bilaterals. First thing, exposure, you just need to see medial condyle, do not release anything. So pose to expose, do not release anything, just need a space to put your tibial jig in. Don't try to go mid sagittal plane and do silly things, it will overcorrect easily. So make sure you use your retractors and do not release on the medial side. Remove all the osteophytes present. Easy way is to remember an Oxford clock. You can go clockwise or anti-clockwise, but you have to remove 2 bones from the femur and 2 bones from the tibia. We will talk about this in a workshop. This jig is very unique. It starts balancing your knee before you cut the tibia. I think that's the first and foremost thing we try to do with robotics in modern time. We put spoon or anything, you try put an osteotome, you just distract, you balance your ligaments. So here you have a 1 millimeter, 2 millimeter and 3 millimeter thickness spacer as a spoon. You can select your bone resection in 1 millimeter precision depending on your choice, and this will be very accurate like 3 and 4, and 7 degree slope is inbuilt. You don't need to apply your brain and you don't need to do any robotics for this. It's a 7 degree for all patients. So you don't need to reproduce, it's ultra congruent design, and make sure the knob is not broken. Sometimes your jig has a broken knob and you will be in big trouble if you don't pay attention to it. The spoon is very important, it feeds a lot of things. So feel the gap between the tibia and femur, it distracts the medial ligament and it avoid cutting the too much tibial bone. So I think it's very difficult to decide tibial cut based on a stylus kind of thing in uni. It doesn't make sense, it's very arbitrary. You have to balance your medial structure. If it is this kind of defect, you need to still balance your flexion gap, and then you take minimum tibial resections. So there are 48 ways you can cut the tibia as per your gap balancing, depending on the combinations of your spoon, clamp, slotted shim and non-slotted shim. So if you have obese female patient with lateral laxities and loose ligaments, you really can play with this system and make sure you never end up in a thicker poly, small tibia and painful uni post-operatively. So avoid this kind of large, thick biscuits. This is going to be definitely a painful uni at the end. So the easiest way to remember, plan this marigold rather than the Oreo. So Oreo kind of biscuit is not a healthy biscuit for uni. Plan the marigold biscuit, thin and large. Make sure you do not cut posteriorly too much, or you will end up in a posterior cortex weak, and make sure you are parallel with the tibial cut. Now the thing starts with your fingers, because this is going to be the absolute depending on your feel part, because it's a proper gap balancing technique. So this is where you have to remember, this is where the Oxford comes in picture with this kind of thing. You can push anything inside with a force. You decide what force. So what crime you do to begin with the first step, lastly your poly will not go, and you will say the poly is not going because you had pushed this thing to begin with and distracted the ligament, and it is not going to generate the proper sizes. So this is the pulp pinch, and lateral pinch is okay when you put and balance your knees, but never push with your hand at the back, and it will definitely go. You feel this is the right size, but then your poly will not go at the end. This is good, and this is you have to achieve. So we will talk about this, the 3-in-1 kind of coupling. This is the beauty of modern microplasty instrumentation system. Never ever hammer this intramedullary rod. This is my own case where only one time I hammer it and I ended up in a perforation of a cortex. Very poor positioning, but still this uni is working well, thank God. But this should be avoided every single time. Never ever hammer the rod. There is always a yellow knob, use it. And you have to link it right. We will talk about this. This is most important. We call it as a wisdom cut, that posterior condylar cut. When you do not drop your hand, you will end up in a 0.5 millimeter less thick posterior condylar cut, and it will going to be a tight flexion gap, and you had measured it before, and after here you are not going to measure. You will end up in a trouble that your poly is not going. And that's why Oxford recommend to start with a 4G clamp in male patient, get things accustomed, and then you have an option of 3 millimeter bearing. But if you start with 3, you do not have 2 millimeter bearing. So 4G clamp to start with in male patients. And this is a flexion drill guide, is a flexion guide as well. It helps you that you are perfectly fine. And what will happen if you do not cut, your 6 millimeter hole become oblong, because your posterior cutting guide is resting on this and trial femur is flush with this. So it reduces the posterior the flexion gap, and you will end up in a tight flexion gap. And these are the problems most of the time surgeons face, that the poly they will feel was too tight at the end. So the spigot science, I think we are going to talk when we have a demonstration. Never ever hammer the spigot once you